Hello, I am Michael Todd. I am one of the trauma and acute care surgeons associated with the Lake Havasu Regional Trauma Center. And we're here to talk today about head trauma. If you look at this slide, you can see a manifestation of Battle's sign, which can be associated with an increased risk of basilar skull fracture. So what are the unique features of brain anatomy and physiology that affect patterns of brain injury? Well, the skull is encased, or the brain, should I say, is encased with a rigid, non-expansile, bony skull. And that cavity that's created is filled with brain tissue and cerebrospinal fluid and blood contained within both the arteries and the veins of the space. That cerebral blood flow is usually in the healthy patient autoregulated, and that autoregulatory compensation is often disrupted by brain trauma and its resultant mass effect. And this is diagrammatically shown in these little cartoons here. And which was first described by Monro-Kellie. The tube here is a representation of the intracranial space, which is fixed in nature, which has valves on either side, which the system can compensate for increased mass effect by releasing amounts of cerebrospinal fluid and venous volume. And that's what we see in this situation here, in which the brain tissue volume is not compromised despite the presence of a mass lesion, like a rapidly expanding hematoma, because the physiologic response allows compensation by removal of excess cerebrospinal fluid and venous volume out of the cranial cavity. But at some point, the capacity of the system to further maintain a constant intracranial pressure by this mechanism becomes overwhelmed as the mass effect increases like with an expanding hematoma. And in this decompensated space, that pressure is then manifested and directed against the persistent brain tissue, which becomes compressed. This is also graphically represented by the body's ability to compensate initially for increasing volumes and pressure by maintaining a constant intracranial pressure despite an increased volume within the cavity. At some point, when the Monro-Kellie mechanisms are overwhelmed, the ability to compensate is lost, and further increases in volume within the cranium result in exponential increases in increased intracranial pressure, which, if unabated, result in uncal herniation. So, like other compartment syndromes, the increase in intracranial pressure can be thought of as an intracranial compartment syndrome, in which normal pressures are around the central venous pressure. Further increases result in necrosis, ischemia, and then necrosis of tissue until treated. Sustained increased intracranial pressure leads to decreased brain function and worsens outcome. And hypotension and low saturation also, as a result, affects outcome as well. So, in the uninjured patient, when autoregulation is intact, the cerebrospinal fluid volume is maintained at a constant, with pressures within a blood pressure range of 50 to 150 millimeters of mercury. But in moderate or severe brain injury, where this autoregulation is impaired, the cerebral blood flow varies with the mean blood pressure systemically, and the injured brain therefore is more vulnerable to episodes of this hypotension, which causes secondary brain injury. It is the reduction or avoidance of secondary brain injury, which is the goal of all medical efforts in the injured brain. How do we classify head injuries? Well, we can do so by the morphology of the associated skull fractures. Fractures of the vault can be characterized as either depressed or non-depressed, and either opened or closed. Obviously, open skull fractures are associated with increased morbidity and mortality, and are similar to the extremity open fractures, with the further caveat of being associated with possible meningitis. Fractures of the base of the skull can be associated with or without central spinal or cerebrospinal fluid leak, and can be associated with cranial nerve palsies. We can also classify head injuries based on the morphology of the associated brain injuries. These brain injuries can be focal, as is seen in epidural, subdural, and intracerebral bleeds, or can be diffuse in nature, as is associated with concussions, multiple contusions, or ischemic injury, say in a patient who's been in a near drowning accident. With respect to focal injuries, a common injury pattern is that associated with the epidural hematoma. This is associated oftentimes with a fracture of the ipsilateral temporal bone, and classically involves a tear of the midmeningeal artery. The hematoma is seen on cross-sectional imaging as being lenticular and convex in shape. This type of injury can be often associated with a lucid interval. That is, the patient will have an initial loss of consciousness and then regain consciousness, and then after a short lucid interval have neurologic decompensation at a later time. These injuries can be rapidly fatal, as they are often associated with the increased pressures associated with an arterial injury, and appropriate treatment includes early evacuation. This is in contrast to the subdural hematoma, which results in a layering of fluid within the intracranial cavity along the surface of the brain, because the blood loss is not inhibited by the attachments associated with the dura to the internal surface of the skull. The morbidity and mortality is oftentimes due to the underlying associated brain injury. Rapid surgical evacuation is recommended in large hematomas and those that are associated with midline shift. Another type of intracranial hematoma is that of the diffuse parenchymal hematoma. These injuries are often associated with coup-contra-coup patterns or point-counterpoint patterns, in which injury occurs at the site of the direction of force and at the opposing portion as well. This commonly occurs in the frontal and temporal lobes, and CT changes can oftentimes be progressive. These are not usually drainable, and in conscious patients, oftentimes surgery is avoided. Diffuse brain injury can be manifested on 2D imaging, as is seen here. There are no evidences of increased intracranial pressure. The ventricles are midline and are of appropriate volume. There's also a nice distribution of the gray-white interface in this normal patient, as opposed to the patient who has diffuse injury, in which much of the gray-white distinction is lost, and where there is evidence of increased intracranial pressure because the ventricles are compressed shut. How else can we classify head injury? Well, we can classify them based on severity by their Glasgow Coma score. These are often compartmentalized as mild, moderate, or severe. The mild brain injury is associated with a Glasgow score of 13 or greater, and oftentimes does not require radiologic investigation. These patients are able to elicit a reliable history, and these patients should undergo workup to exclude other systemic injuries. If their neurologic exam is normal, then radiographic investigation is only as indicated. These patients are often observed and may be discharged based on further findings. Patients who sustain moderate brain injury demonstrate a Glasgow Coma score of between 9 and 12. All of these patients, in addition to those evaluations that occur for mildly injured patients, obtain routine CT scans. These patients are generally admitted and observed, even if for only a short interval. And during their admission, they receive frequent neurologic examinations and undergo repeat CT scanning to identify interval changes. This patient should a patient in this group develop deterioration, they are then managed as a severe injury and not a moderate injury. Severe brain injuries are patients who manifest a Glasgow Coma score of less than 9. In addition to the interventions that occur for less injured patients, these patients undergo endotracheal intubation to protect their airways. The intubation is preceded by a neurologic exam that is unaffected by paralyzing and sedative agents that are oftentimes required for an acute intubation, and frequent reevaluation of the focused neurologic exam is used to define patients who require further interventions. As in all neurologic injury, these patients undergo further evaluation to identify associated traumatic injuries. So having said all that, which patients need to obtain CT scan? Well, any patient, even mildly injured patients, who have a Glasgow Coma score of less than 15, still 2 hours after injury, should receive a CT scan if they have not already had one. Certainly patients who have open skull fractures, signs of basilar skull fractures, or persistent neurologic deficits should undergo a CT scan of the head. Patients at extreme of age and patients who have vomited more than once should also obtain CT scans. Patients who have severe headache or retrograde amnesia should also be CT'd. So what is the optimal treatment for patients with brain injuries? Well, you treat these the same as any other trauma patient. You first evaluate airway, their ability to ventilate, and you evaluate for circulatory shock. You minimize the secondary brain injury by administering oxygen and maintaining adequate ventilation and blood pressure. So what is the focused neurologic examination? The focused neurologic examination includes the Glasgow Coma score, pupillary characteristics, and lateralizing findings. Medical management of increased intracranial pressure and brain injury, again, involves adequate oxygenation and ventilation, normalization of end-tidal CO2, and euvolemic resuscitation to maintain adequate perfusion pressures. In some patients who then go on to develop signs of tentorial herniation, as is often suggested by enlargement of an ipsilateral pupil, mannitol is given as a precursor to surgical decompression. We avoid mannitol in patients who are hypovolemic, who are often in that state because of other ongoing bleeding injuries. Another tool in the armamentarium is the administration of hypertonic saline to avoid undue swelling. Intracranial hypertension can also be controlled with anticonvulsants, adequate sedation, and when necessary, paralytic agents. Scalp wounds are controlled with direct pressure and occasionally with temporary closure. And penetrating trauma patients should receive prophylactic antibiotics, but should not have their penetrating objects removed, nor should wounds be probed. The intracranial mass lesion, if rapidly expanding, can be life-threatening and requires immediate neurosurgical intervention. How is brain death diagnosed? It's diagnosed by an unresponsive patient who has bilaterally dilated and non-reactive pupils in the absence of brainstem reflexes, who makes no spontaneous ventilatory effort on formal apnea testing. These patients can be preserved and are possible candidates for organ donation. So in summary, we manage head injury patients after understanding basic intracranial physiologic parameters. And we evaluate these patients optimizing their airway, breathing, and circulation, as we do for all trauma patients. We search for associated injuries, and we adequately resuscitate these patients, which is important in limiting secondary brain injury. Here is a recent patient who sustained a blunt force to the right temporal region of the skull. Here is his CT scan, which suggests a fracture of the skull in the frontotemporal region. And lower cuts through the temporal bone further demonstrate this depressed fracture. A recent laceration in the area was repaired in a timely manner with the application of skin staples. And there is evidence of a large amount of subcutaneous hematoma and midline shift, suggesting intracranial hypertension. The presence of the epidural hematoma is seen here and here. This is an epidural intracranial